Welcome back to this week's edition of Freedom and Prosperity Radio, the weekly radio news magazine we put together here at the Virginia Institute for Public Policy in a Commonwealth that both at once is the birthplace of the idea of self-governance, and yet in this modern iteration, it becomes almost a Mother May I state where everything has to be legislated by the General Assembly. We continue to keep an eye on what's going on there. And joining us now, founder of YourChoice Direct Care, Dr. Chad Savage is back on the program. Great piece in Real Clear Health, an article, Healthcare as Simple as Streaming 111. And I appreciate it, Chad. Welcome back to the program. I hope the new year has greeted you well. How are you doing, sir?
Yeah, great. Hopefully it's still it's not too late in the year to still say Happy New Year.
No, not at all. I said, yep, yeah, it still has that New Year smell, so it's good.
I guess it's the New Year until you figure out what to put correctly on any document you're dating.
That's right. When you automatically write 23 down, and it's now you're working towards the end of the next one. So as we approach this, I know that there were a lot of folks with a lot of chips in on a table on a new Congress, and perhaps able to legislate nationally better access to health savings accounts and things like that. But I still wonder if there's still not that opportunity, especially amongst members of the U.S. Senate that might be concerned for their tenuous position in a year and a half or so. Chad, from where you sit as somebody who operates a direct primary care physician's operation, is health choice something that we're still on track to start legislating soon?
Well, it could be. People have asked me, what do you see in the next year? Do you see things getting better or getting worse? And it very much depends on which track we choose to take. We may have a Congress that's a little more care system have occurred from the excessive centralization that's occurred with the decision making. And if you think about the ultimate centralization, it's putting all the decision making in D.C., and the ultimate decentralization is keeping the decision making with the individual. Mm-hmm. And people like myself feel that as close to the individual for the decision making as possible, the better outcomes you're going to get, because they're the true arbiters of good quality health care, because they know it, they're the ones receiving it.
As time has gone on, and we see more and more influence of some of the care panels that the government has, and the advisability of care panels, and the impact they have on families, I think more and more people are realizing that if they want to get somebody, some treatment, or if they want to get some treatment and have the wherewithal to do it, just to be told the government isn't going to kick in their share, so therefore you can't do it. I think people are waking up to what really was going on in the Patient Protection and Affordable Care Act, aka Obamacare.
Yeah, it was funny that you bring up ACA, Obamacare, because I was just looking at some historical data for context as to what's occurred since then. And for one, just the personal experience, I've been a physician for over 20 years, and so I've had the privilege to see the changes that have occurred. Unfortunately, it's a negative privilege. Yeah. Back in the 2000s when I started, if I wanted someone to see a specialist or something, they could get in almost same or next day. It was unbelievable how responsive those specialists were, because we were the ones who fed them. Well, ACA came into effect, and doctors' productivity dropped down the hole because they were so inundated with non-medical care processes. They were filling out form, tracking metrics, and basically they're being distracted from their true calling, which is patient care. So their availability dropped like a rock, to the point now where we're looking more and more like Canada, with 6 months waits to get in to see specialists. Mm-hmm. And we have such short memories in the United States. We seem to forget that's not how it's always been. This is a new thing, and certainly the pandemic has exacerbated that. But that was occurring. That the expanding wait times were developing prior to the pandemic. And Gallup did a study or a survey back in the late 2000s, in 2008, and 87% of respondents at that time indicated that they were satisfied with their health care, and that in the intervening slightly, about 14 years, 15 years now, and going into 2023, has dropped to 40%. So they've more than cut that satisfaction rating in half. And so there were problems in healthcare certainly in the 2000s. I'm not saying it was idealistic or idyllic, but boy, have things been made worse. And perhaps in the attempt to make it better, they've actually made it grandly worse.
Well, and I remember when President Clinton was elected, and he announced that he was going to have this all-hands-on-deck commission to look into fixing health care, and his wife was going to manage it, and it was going to be full of insurance providers and hospital corporation owners or CEOs, and everyone lost their mind saying, you're going to do what? And the cartoons of foxes and chicken coops and that kind of thing. Yet during that time, the insurance industry became stronger and stronger managers of health care, and the health management organizations became bigger and bigger, and the world where just a major medical health insurance policy, which was pennies on the dollar compared to an HMO membership, really became almost arcane and relics of the past.
Yeah, and what those older catastrophic type insurance plans did is they kept the money in the pocket of the individual who was purchasing them, and they were really a better, in my opinion, ideal of what insurance is supposed to be. Insurance is designed to be a hedge against catastrophic financial loss. Mm-hmm. Unfortunately, they're so expensive now. The insurance itself is the catastrophic financial loss, with premiums in the range of $26,000 for an average family health insurance premium. Well, if you look at prices of surgeries, for example, if you go to the Oklahoma Surgical Center, which is one of the cash pay surgical centers, that is probably the closest approximation to what the surgery truly should cost, you could do 2.5 spine surgeries for that.
What?
And so, they're around $10,000, for a single level laminectomy at the Oklahoma Surgical Center, where you get preoperative management, operative care, the surgical fee, the surgical center fee, and postoperative care. So it's a wrap price. It's right around $10,000, and you compare that to the surprise billing laden aspect that we have with the insurance care, where that same surgery is going to be around $100,000 or more, and you never really know what it costs because they keep sending bill after bill after bill after the fact when you can do nothing about it. At places like the Oklahoma Surgical Center, you know prior to the surgery what it's going to cost. So you can plan for it, and you're not getting the surprise bill, and it's much, much more affordable. Mm-hmm. So again, that insurance, the concept is to be a hedge against that catastrophic loss. But who would do 2.5 spine surgeries every year? You're doing the equivalent, paying the equivalent for a family of 4 as 2.5 spine surgeries every year, and that's absurd. You need an inexpensive coverage product that covers calamitous, rare events, so that individual not spending that much money on their premium has the money available should they actually need it. Like an ER visit.
Well, if you take the math and pencil it out, and Dr. Chad Savage is on with us, founder of YourChoice Direct Care and one of the leaders in the direct primary care world. But if you take that math and that number and you put it in a health save, even if you do a half, and right here at the Virginia Institute for Public Policy, along with Health Freedom, we're working on school choice, and we're talking about money follows the child's school choice into education, whether we're calling them success accounts. But if you took that $26,000 and just half of it went into a health savings account that you didn't have to disperse, and you could just build like a 401k, by the time you turned 60, you had enough money. You weren't worried about Medicare. We could reform and save these, quote, entitlement programs that Washington is so concerned about if we just took our head out of our legislative backsides a little bit and realized that if you just let the patient build this, number one, it gives more venture capital into the system anyway. But beyond that, it becomes a robust account where you have so much money by the time you get to your elder years, you're not worried about your health costs when health costs go up and your income goes down.
Yeah, absolutely. And actually, several years back, I wrote an article of my own experience doing something analogous to that. So we always talk about health sharing, which is an alternative to traditional insurance, but it functions like insurance. It's much, much more cost effective. But I wrote an article in Town Hall several years ago about my own experience of the first 5 years after I left our health system and had to obtain my own coverage. And by combining direct primary care, which is much more cost-effective primary care, it's very responsive. The quality care is much better, and it's in a membership model, so it's affordable and predictable. My family saved $88,000 in 5 years over the premium cost of the insurance plan alone, which
Wow.
if you extrapolate that out to a decade, that's a modest house in savings. They always say the most expensive thing you're going to buy in your life is your house, but I'd actually argue it's not. It's your health insurance. But if you were to then expand that over the working years of that individual's life, you would have a really nice nest egg in savings that can be used as you see fit, which again gets the decision-making back to the most ethical
Sure.
location of medical decision-making, which is with that individual and with the guidance of their physician, because they're not looking to surrogates in the government and insurance companies to make those decisions. Because fundamentally, this comes down, unfortunately, to rationing, and no one likes to think of it that way. But we're in a world of finite resources, so decisions have to be made about what is to be done and not to be done. Well, we feel like patients shouldn't have to be involved in that, so we have the surrogates do that, the insurance company and the governmental agencies. But then there's ethical issues with that. They can make a decision that may be good for 80, 90% of the population, but what if you're in that 10 to 20% that is a horrendous decision for?
Yeah.
Well, those aren't addressed. So again, the reason those entities have to make those decisions is because we've created them as surrogates for that decision-making by giving them our health care spending money, in the form of taxes and premium and such. But if some of that has to be done for, again, rare catastrophic events. But if you keep most of that money with the individual, keep it in the form of an HSA or something of that sort, and now they don't need to get authorizations for medications and CTs. They're consumerized. They're going to go to the most cost-effective quality location. They don't have to get authorization for the meds. There's going to be a consumer-driven downward price pressure for these pharmaceutical companies and such not to overprice it, because the patients now controlling those dollars aren't going to pay exorbitant amounts.
Right.
So truly, supply and demand and classic free market principles are constraining mechanisms which constrain the extravagance of the healthcare system and would make it like every other industry where it prevents the predation of those entities.
On this week's edition of Freedom and Prosperity Radio, we're visiting with Dr. Chad Savage, founder of YourChoice Direct Primary Care and Great Peace at Real Clear Health. He wrote just before Christmas on health care as simple as streaming 111. I want to pick up on something you just said there about what we've created, and I'm thinking in terms of how obvious this is, but how thoroughly convinced or gaslit or just sold on the idea that healthcare is different. Healthcare is different than buying a car or shopping for a home or clothing, and that it needs to be this mystic pursuit of the dragon in the mountain, and that you need the government and your great insurance company to help you in your quest. And how do we unring this bell? Because I run into people, intellectually sound people, who's like, oh no, you have to have a healthcare HMO. You have to, just because that they're the ones who organize everything. And I remember the early ads for HMOs and the poor sad sack with a pile of papers that he was, oh my gosh, and my copay, and what do I do? And it's like, save all that, join the HMO, and Blue Cross, Blue Shield will do it, just a card, and it was sold on this idea of simplicity, which is laughable now anyway. But how do we untell this fairy tale about healthcare not being something that can be handled just like any other consumer product?
Well, yeah, so there's a grand fallacy, and that's healthcare is too complex for people to understand it or manage it themselves. And actually, I was even told that as a physician leaving the insurance industry, that a practice and going back to patients, like, you can't do that. You need this massive infrastructure behind you to practice medicine today. It's so much more complex. And it's true, technology has advanced in healthcare, but we actually, I would believe, practice a higher level of medical care with a 1-to-1 ratio, meaning I have one full-time employee per physician. in my medical practice. And I compare that to the 6+ full-time employees I had, administrators at the hospital, billing and coding people behind the, subcontracted out, et cetera, all to deal with the Byzantine labyrinth of a system that we currently have. And people will talk about individual policies, and I could do so probably until you fall asleep tonight, if that was what you wanted to do with the current system. And they'll talk about improving or reforming these individual ones. But I've come to the firm conclusion that you can't do enough minimal improvements of the current system. In reality, it's kind of like paint peeling on a wall. So if you put the initial coat on, it gets old, it starts to peel. You try to put another coat on, you still got those peeling chunks,
right.
But now that new layer starts to peel. And we have many tens of layers of paint on this system now. We need some paint thinner on that to go strip those walls bare and start over with a fresh coat of paint.
Yeah.
So though I could talk about medical loss ratio and the bizarre incentives that injects into the system, the fact that physicians from 2010 to 2014, when ACA went into effect, lost about 20% of their productivity, which is equivalent to essentially an entire day in a 5-day work week, now just spent on bureaucratic processes and the effects that have. I could go through all these different problems, but the fundamental nature is we got to get a lot of that out of there and consumerize the industry. Mm-hmm. And people will say, well, you can't do that. Healthcare is different. You can't shop around. Well, you absolutely can. The National Economic Council under the prior administration actually estimated it was around 85% of all medical transactions were consumable, meaning people could shop around. Most of it's truly not emergent. That's always the red herring that is used to scare people away. Well, what if you're bleeding to death? You can't shop around for that hospital. And that's true in that moment. But I'll tell you what, if you are taken advantage of in that situation, and they may be able to stick you one time with an incredibly high bill, but you know what you'll never do? You'll never go back to that hospital. So any hospitals that did engage in predatory practices would actually go out of business because they get a horrible reputation. And you'd be able to allow competitors into the market that would prevent that. So I would actually argue even those are consumable in the long run. Just like if your car breaks down on the side of the road and you call a tow truck, the government doesn't generally have to regulate that. You don't know at the time that tow truck arrives how much it's going to cost. And sure, they may elevate that price a little bit because of the urgency of the situation, but they don't go crazy because, again, that consumerizer, consumable nature of that transaction, no one will ever use that towing service again if they are really abusing their customer base.
Well, and certainly in this day and age, our ability to spread the word about that kind of thing has gotten so much better. I mean, I remember growing up in one of the largest cities on the planet, and my doctor worked out of the basement of his house. He had, a 2-story house in Queens, New York, and his garage and the basement level was his medical office, and that's where he worked from. And there was no need for him. And if something was wrong, my mother called him, and then he said, well, bring him to the hospital. I'll meet you there. That was sort of how the system worked then. Do you think we can get back to that personalization where more physicians just hang a shingle out in a neighborhood and they treat the kids in the neighborhood and the adults in the neighborhood as a GP?
Yeah, not only can we, I know it's already occurring because our model is actually doing that. We actually have doctors within the direct primary care movement who even do house calls and things of that sort. They'll open their hours at their office at any hour to handle a laceration and such. I'm an internal medicine doc, so I don't take care of kids per se, and I actually don't do house calls, but about 20% of the direct primary care doctors do. So that, and I'll tell you what, this is the beauty of markets and pressure. If that became such a huge thing that everybody was leaving my practice and going to some direct primary care doc who opens up an office down the street from me, I would be forced to expand my service provision because of that feedback. It's a great mechanism. People they try to create all these ratings and things of that sort for doctors. Well, the ultimate rating is when people shop with their own dollars. Yeah. How do I know that we're doing a reasonable job? Well, people keep paying the membership. If they don't think we're doing a good job, they stop paying us. And that's a heck of an incentive to us to either provide a better level of care or a lower price for our service.
Well, and I want to finish up on your subject matter because our policy director and I have had some great conversations about technology and the future of healthcare. So you're talking about the human aspect of it. I'm going to take it and, in many people's eyes, dehumanize it, but I think our ability to access more and varied doctors through streaming services and that kind of thing, telemedicine, where do you see that in this paradigm, especially, I guess, more as specialists come along, right, Dr. Savage?
Yeah. Well, it certainly could be a huge advantage for the underserved areas in inner cities and in rural areas, specifically for psychiatric evaluations and treatments where the physical exam is maybe a little less important. It's funny. I think actually our system is doing it. This is just my own perspective. I think we're doing it kind of backwards right now. We're trying to treat illness specifically through remote means. But actually, when the reason why we need to see someone face-to-face is because the examination has a reason and a value. And we tend to bring healthy people in for the routine screening exams, which, an examination in those individuals has some, use. We could stumble upon some pathology that's otherwise asymptomatic. But actually, those sick people, we know they have pathology because they're sick. So that's when it's most useful to see someone in person. I think the biggest role for remote treatment is actually for maintenance, like blood pressure management, where somebody can use a cuff at their own home, create their own numbers, send them to the office. We can review those remotely and modify medications remotely with really almost no clinical detriment because we're omitting the exam in an asymptomatic person who's unlikely to have substantial pathology.
And that's interesting, sort of the maintenance of the current customer, as it were, and just saying, hey, here's my blood pressure this morning, doc, and you don't even have to worry about setting off that time because I've talked to doctors who have become part of hospital systems, and orthopedists went from a half an hour per patient to 7 minutes per patient once they went into these hospital systems. And I just don't know how you do good medical care. God bless the nurse practitioners, I guess, that carry a lot of that. Are there other things as we finish up, like expanding the role of the nurse practitioner, expanding, what access to those sorts of policies? Will that help democratize this, bring it back to the free market?
Well, we certainly have a deficiency in the number of providers out there, which is one of the reasons we're seeing these expanding wait times, not only the decreased productivity because of the increased procedure burden that are being placed on them, but there's simply not enough of them to begin with. So nurse practitioners, physician assistants are going to help plug that gap to a certain extent as long as they kind of understand, like I do as a primary care doctor, where my limits are. I can't treat everything. That's why we have specialists and nurse practitioners and physician assistants have slightly less training than that. So it's in the past people have asked me, am I threatened by this? And not really. I think that my medical degree has a value. People, generally speaking, want to see a physician. But for those who can't or don't want to, those nurse practitioners and physician assistants may be able to price point a little lower than we can. And if that's the difference between somebody accessing care and not accessing care, well, then it is an overall good.
And again, the website is YourChoiceDirectCare.com. I know there are some direct primary care doctors in Virginia. I wish there were more of them, but it's growing. And Dr. Chad Savage, thank you so much for your time this week on Freedom and Prosperity Radio.
Always a pleasure, Joe.
And thank you for joining us on behalf of Chad and Joel and all of us here at the Virginia Institute for Public Policy. Until next week, my name is Joe Thomas. So long, and thanks for all the fish.